Morning, everyone. Um, just to give you a little background, you know that ILBS is a WHO collaborating center for hepatitis and chronic liver disease. It became the second WHO collaborating center after CDC Atlanta. Dr. Sareen is part of strategic and technical advisory group at WHO CRO. ILBS is also part of now regional validation advisory group at Western Pacific region of WHO, and last week I was there as a part of the group. Why I'm mentioning these three things? Because global health sector strategies which are developed by WHO, which I'm going to elaborate, basically the collaborating centers, these advisory group contribute significantly to these global health sector strategies on hepatitis. So in my talk today, I'm just going to deal with what is the global epidemiology, what is the burden of disease globally in Southeast Asia, India, what are these strategies basically which call for ending hepatitis by 2030, what is the current status, how far we have progressed so far, and what will it take to eliminate hepatitis. You know, in 2015, World agreed to have sustainable development goals, which was basically a plan of action for people, planet and prosperity. You know that there are 17 sustainable development goals, out of which many are linked to health directly or indirectly, more than 6. But the goal 3 is specifically for good health and well-being. And within the goal there are targets, and target 3.3, it says end the epidemic of AIDS, tuberculosis, malaria and neglected tropical disease, and combat hepatitis, waterborne disease and other communicable diseases. We know that hepatitis is a major public health threat. It is the only communicable disease. While HIV and TB, there has been significant decline in mortality, but here the mortality is still increasing as per latest available data released in 2024. This was a Lancet Gastroenterology Hepatology Commission, basically in 2019, which shows that 70% of viral hepatitis deaths happen in 20 high burden countries, and 11 of these are in Asia and 5 in Southeast Asia. It also shows that disability adjusted life years in 20 high burden countries and significant dailies basically were happening in China, India, Pakistan, Indonesia. In 2016, WHO came up with the first global health sector strategy. Before that, there was no global health sector strategy. This started the focus of action on eliminating hepatitis as a public health threat. And what does elimination means? There is a difference between eradication and elimination. You all know that. For hepatitis, it means that by 2030, there is a 90% reduction in the new infections and 65% reduction in deaths related to hepatitis, which translates to 900,000 new infections by 2030 and 500,000 deaths, which is a significant decline which we are anticipating over the years. And how these targets were achieved? This was through a modeling study basically, which says that if we have 5 core interventions with sufficient coverage, this will lead to these elimination targets, which is 90% reduction in new infection. And what are these? These are pertaining mainly to prevention. 4 are due to prevention and 5th is due to testing and treatment. So these interventions include that we should have at least a 90% coverage of 3 doses of hepatitis B vaccine, 90% coverage with HPV PMTCT, that is prevention of mother to child transmission. Earlier this was restricted only to a birth dose of hepatitis B vaccine, but now this includes also providing antivirals, tenofovir to pregnant women who are hepatitis positive. 100% blood safety, injection safety, and then 90% of the people are diagnosed who are estimated with the hepatitis, and 80% of them are provided with the treatment. If we are able to achieve, then we will be able to reach our elimination goals. So let us see what is the global burden. We have almost 304 million people. This has come down from 354, which was in the last report, but this was a global hepatitis access report released at Lisbon in April. 304 million people are living with hepatitis B and C, out of which 254 are with B and 50 with C. This gives you a distribution of hepatitis B cases over the different regions of WHO, and out of 254 million, if you see in Southeast Asia, 61.5 million are in Southeast Asia. If we see similarly for hepatitis C, out of 50 million who are living with hepatitis C, Southeast Asia is almost 9.1 million. These are the estimates. It has also shown that 2/3 of the global burden is combined in 10 countries, which include China, India, Indonesia, Nigeria, Pakistan, Ethiopia, Bangladesh, and these are not all very high burden in terms of population, except China, India, Pakistan, Ethiopia, Bangladesh, they also contribute significantly to hepatitis B and C burden. If we just split it by B and C, if you see, India contributes 11.7% of total burden of hepatitis B infections, following China. But if you look at now at C, it is the Pakistan, which is significantly contributing 17%, though its population is much less than India. India contributes 11%. Why it is so? Some of the reasons which have been identified are basically rampant unsafe injections. That is what has been postulated, not the injecting drug use, which is in parts of the countries, India and other countries, but it is more of unsafe injections, particularly in Pakistan. There have been some documentation around. If we go to now Southeast Asia region, the prevalence of hepatitis B surface antigen, which is a marker of the prevalence, is around 3%. But if you see among children which are younger than 5 years, it is around 0.4%. And our target is to bring it to less than 0.1%. That is what is one of the impact indicators for elimination. And if you see prevalence of hepatitis C, this is 0.5% in Southeast Asia. Moving a little bit down to India, this is the latest data which has been published by National Viral Hepatitis Control Program, and the data comes from National Family Health Survey, in which the hepatitis B and C seroprevalence was also seen. If you see, the prevalence in India is around 0.85%. If you see, that is the average. But we have got at least 9-10 states which has got prevalence higher than the average, which going as far as 1.4% in Bihar, Mizoram, Delhi, Madhya Pradesh, Meghalaya. So these are states which have got more than average of the country average. Similarly, in hepatitis C, we all know that it is much more in northeastern countries, but if you see, the seroprevalence is more than 1% in Mizoram and also in Punjab, and some of the other states are including are Haryana, Uttarakhand, Karnataka, and you might be a little surprised that Punjab, you have always been reading about drug use. What about Haryana? We don't see many of people who inject drug in Haryana. So why the prevalence is high? So again, it has been seen that this is more due to a habit of the people asking for injection from healthcare providers, more of injectable treatment and unsafe injection, repeat use. So that way the Haryana also has got a high prevalence, and the national seroprevalence is 0.29%. So going a little bit more into the incidence, as I said, the number of new infections has declined globally from 2.5 million to 2.2 million in 2022. Out of these, basically 2.2 million, 1.2 million are hepatitis B, largely preventable by single vaccination, birth dose and 3-dose vaccination. And nearly 1 million are hepatitis C. Almost 6,000 people are getting newly infected. 6,000 people every day get viral hepatitis globally. Similarly, if you see deaths have increased from 2019 estimate of 1.1 million, and now it is 1.3 million. And it has been suggested that this increase is due to increase in number of hepatitis related cancer cases. That is why the deaths are increasing. This has been postulated. And 83% of deaths are due to hepatitis B. This again shows that what are our targets. Basically 2025 we want to bring that down, that mortality from hepatitis B to 530,000. By 2030 we want to bring it to 310,000. That is what the target is, but presently if you see 2022 status, it is almost double than what is our target of 25, which is just 1 year ahead. So we have to really think as hepatologists also, are we adequately diagnosing people in time and providing linkage to the treatment. In Lisbon conference, again the World Hepatitis Alliance, WHO sounded an alarm that almost 3,000 people die, 3,500 people die every day from hepatitis. I don't think that is acceptable to any one of us. As a premier institution, we have to see how can we contribute to reducing this. This is just to show you the trends in the incidence and mortality of hepatitis B, and the line, and the green line you show is the incidence, and the blue line is basically about the mortality. What are our basically planned target? But if you see, again as I said earlier, the mortality is increasing and the incidence is not declining at the pace that is required. Similarly for hepatitis C. Let us see what have we done so far globally. Less than 15% of 254 million people are aware of their status. just less than 15%. It is actually 13.4%. And 40% of people are aware of hepatitis C status. Just a simple test costing less than 30 rupees in India and less than $1 in most countries. Treatment, just 3% of people living with hepatitis B, 254 million, just 3% are getting treatment. Similarly for hepatitis C, which is curable with 12 weeks of course, just 20% of people are getting treatment. And this again shows a regional coverage. I don't think you will be interested in all the regions, but if you see in Southeast Asia, it is diagnosis is just 2.8%, not even 13%. Hepatitis treatment, B treatment is 0.1% of 61 million, just 0.1% receive treatment. It's simple drug, once a day, tenofovir. Hepatitis C, again, the coverage, global coverage is 36%, but in Southeast Asia it is 26%. In India, just 2.74 lakh people are getting treatment for hepatitis B and C. Just 2.74 lakh. Again, the modeling has shown that if we are able to provide treatment to 40 million people for B and 30 million by hepatitis C by 2026, we can achieve the target that we are aiming for. And this will also reduction of 2.1 million incident cases of hepatocellular carcinoma which are averted, and 2.7 million lives are saved by expanding this treatment. Now coming to barriers, what are the barriers? Why are not we progressing ahead at the pace despite availability of the drug, tenofovir, DAs, 12 weeks, why we are not moving ahead? Cost is an issue. In many countries, cost is an issue. We are focusing on India, but if we look at global, because this is a global presentation, the cost of even doing a CVRNA comes to almost $80. In India, it is just $8 to $10, 800 rupees, 900 rupees, but it comes to $80 in many countries. Similarly, if we see hepatitis B, the price that has been fixed globally by WHO, and it is actually an agreement with the suppliers, the hetero and Viatris, that you will supply this for just $2.5 a month, tenofovir. But what you see is that many countries, some countries are getting at $1,800 for 30 days. It is a lifelong treatment. So access to treatment is also an issue. Similarly, if you see hepatitis B, just 7 countries, there are 26 focus countries for hepatitis B elimination, just 7 countries pay that price of $2.4. If we look at DAs, Sofdec should not cost more than $60. Sofvelpa should not cost more than $170. And it is not hypothetical. This is the agreement with the pharmaceuticals that they will supply at this rate. But if you really look at this rate, only out of 26 countries, just 2 or 3 countries are getting at this rate. India is fortunate, and I am talking of generic drugs, not the patented drugs. India is fortunate that the cost of treatment in our country is around $45 for 12 weeks course of Sofdecla. Coming to another prevention, hepatitis B, we know the hepatitis B transmission is mainly perinatal. It is much of less is during the pregnancy, but most of it is in perinatal, and that is why hepatitis birth dose, B birth dose followed by 3-dose vaccination can really prevent the transmission. But just 45% of infant globally receive that targeted birth dose, the birth dose within 24 hours. In Africa, some of the countries it is only 18%. So just to narrate an evidence, in India this coverage was around 54%, and when we went to Mr. Amitabh Bachchan, who was our ambassador for Sero for hepatitis B, he said how much it costs. We told him it just costs 10 rupees. He says for a 10 rupees dose you are able to prevent hepatitis infection. Why we are not able to scale up? Of course there are challenges because deliveries happen at sub-center level also where the availability is an issue, but we had a campaign, we tried to develop a campaign from WHO, and I remember Dr. Sareen was in that meeting in Bombay. This was Global Hepatitis Day celebration, and this was raised by you, sir, also at that time. The coverage has gone up to now 74% in India with efforts, but still we are not at the, even among deliveries which happen in the institution, still the hepatitis B birth dose is not provided to all. This is just to show you, these are all the grey countries which are having less than 50%. If you see globally, the coverage is far from what is desired. So in 2022, WHO came up with another strategy. This was extension of the 2016 strategy that we want to integrate. We know that HIV has been a successful model across the globe. In India, the HIV treatment centers basically work as a vertical centers, but they have achieved significant success. There has been almost a 60% decline in new HIV infections and 55% decline in AIDS-related death. But these are all vertical programs. There is no such vertical program for hepatitis, and vertical programs are difficult to sustain over a long time. So WHO came up with a strategy that we should integrate the eliminable diseases, which includes HIV, viral hepatitis, STI, and also coordinate with TB program if we really want to end these. And this strategy also basically showed to the world that if we want to achieve what we want to achieve, and this is the thick line, that we want to reduce the new infections of hepatitis B, but if we do what we are doing now, you will be just at this dotted line. You will not reach the target. So there will be a big gap. So we really want to think how to move ahead in the changing scenario. And similarly, the Southeast Asia came with the integrated regional action plan. So what are the key shifts required? How will we eliminate? First is greater awareness, public awareness. We still know that 10 to 15% of people just know that their status out of these 304 millions. We need to focus on prevention by scaling up universal access to hepatitis B birth dose, as I said. Increase the access to hepatitis B and C virus testing. In India, just 8 crore people have been tested since 2018 when the program was launched. So 6 years we have tested only 8 crore people and provided treatment to just 2.74. Of course, efforts are being made, but I think we need to really think that how can we contribute more to this. Also, we need to have simplified decentralized service delivery. This has been actually demonstrated by ALBS. There is a publication by Ekta and other colleagues which showed that a treatment can be provided even at the level of Mohalla clinic with linkage to the testing labs. Strengthen community and civil society. You know that HIV response has been largely due to a very active community which demands and monitors the response of the National AIDS Control Organization. But there is no such civil society in hepatitis, very little. Reduce stigma and discrimination. During that World Hepatitis Day, I think Dr. Sareen, you presented some instances from ILBS where people who had hepatitis B were denied visas to Middle East countries. Stigma and discrimination is still happening, particularly with hepatitis B. People are, the women who are hepatitis B positive face stigma even at their home. So we really need to work to reduce this stigma so that they can access the treatment. Development of curative drugs. We don't have a curative drug for hepatitis B virus. We still need to develop that. This is evidence from WHO which has been published in the guideline. You can access this, that there are 5 good service delivery health practices, have simplified standardized algorithms which are simple, which can be followed at the primary healthcare level. Strengthen linkage to testing, because many people who are tested do not get to the treatment site, which are not at the same site, and they're lost and they come back when they have developed complications. Integrate with other services, decentralize to primary care, people who inject drugs, provide them treatment where they are, and task sharing to non-specialists. This is what I want to emphasize here. Hepatitis B, C treatment is not hepatologist's domain. This is now a physician's domain or even a primary medical officer domain. Countries, there are evidences in WHO guidelines where this is being provided by nurses. Of course, there will be niche areas where you want to refer it to a specialist, to a specialized institution, but really task shifting is what is required if we really want to reach out to people where they are. Diagnostic innovations. Again, emphasizing, we focus on HCV RNA using the standard labs, but we can do it on point of care gene expert. We can use core antigen. ILBS has actually validated the core antigen for hepatitis C instead of RNA. That has also been validated here. So we really need to have those kind of innovations. HCV self-testing. Now, like HIV self-testing, these kits are available. You can just rub it against your buccal mucosa and see the self-testing. Person can do the testing in his own privacy. Point of care viral load testing, diagnostic integration. We really need to have multi-disease platforms like GeneXpert, TrueNet, where you can test for HIV, you can test for HCV RNA, you can do HBV DNA, and of course core antigen, which I have already mentioned. Improving capacities. Here the WHO CCs come. training modules. WHOCC, ILBS has contributed to these training modules on B and C. Lot of trainings have been done, and now we are planning from the ILBS to have advanced training module for complicated cases with the regional office in Southeast Asia. Advocacy. This is the World Hepatitis Day, where we had this event, the Global Hepatitis Day, only Global Hepatitis Day in India. We also need to work with other agencies, World Hepatitis Alliance, FIND, liver foundations, community engagement, link between hepatologists and public health specialists. And I think the examples are here, Dr. Sareen, Dr. Rakesh Agarwal, many people who have actually linked the hepatology to a public health approach. I would just like to show this picture. This was an initiative led by Dr. Sareen, where we have WHO headquarters, Dr. Yuvan, Western Pacific region, CRO, India office. And at this event, ILBS worked with WHO to launch a guidance document on attributable fraction of cirrhosis and hepatocellular carcinoma on hepatitis B, C and other etiologies. And later on this work was carried out, and Manya has published a paper last year on these fractions. So we are contributing a lot to the global health sector strategies in that way. Lastly, in February 2024, again the Lancet Gastroenterology Hepatology Commission came up, and they said what are the action required. They are almost in sync with the WHO guideline: simplification of care, validation and rollout of simplified strategies, improved diagnostics, investment in simplified diagnostic, financing. We need to show investment case to the planners, to the political leaders, that investing $1, and there are publications that investing $1 now will actually save you $2 to $4 in the long run. And one publication from CRO has shown that this will increase the DALYs by 4.4 years. So to conclude, what are the 10 actions which are now recommended by WHO to basically work towards ending? And these are on 5 strategic directions. The strategic direction are that we need to deliver high quality, evidence-based, people-centered care. And what does this mean? Expand testing, shift the treatment to primary care level, focus on prevention to bridge the gap that is in the birth dose. Strategic direction: optimize systems, integrate the systems, utilize the other health systems, product regulation, procure supply chains, reduce the cost of the drugs in line with the global. Then generate and use data. We hardly have data. What we are saying on the estimates, these come from some studies, systematic analysis, but we don't have real-time data that what is the problem and magnitude of the problem of cirrhosis and this liver cancer related to this. Community engagement. Unless we engage with the people who have actually been affected and got treatment or are on treatment, we really need to work with them. And innovations in terms of newer diagnostics and hepatitis B cure. Just to emphasize on this, one part is for hepatitis B is the gap in the recommendations, that the recommendations say only 20 to 30% of people are eligible for treatment. Again, ILBS in its TAG meetings have been working for treat all approach, and recently the guidelines have been modified. Now the criteria has changed, which will make almost 75% of people eligible for treatment with the change in the APRI score, providing treatment to all pregnant women. So these kind of efforts, BEAT-B is another study which is going on from ILBS, where we look into aspirations of people who are positive, who don't get treatment because they're not eligible. They come every year, spend 10,000 rupees on getting HBV DNA and other tests, and again say you're not eligible. So these kind of advocacies are really required from institutions like this, like ILBS and other institutions, which feed into the WHO guidelines. So to summarize, the greatest challenge is still to reach the unreached. We have to reach 94% of 304 million. Cost-effective strategies. We can't test everyone. We really need to focus whom to test, which pockets to test, which population to test. You can't test 140 crore people in the country. So at risk, partners of the positive, prisons, inmates, homeless, symptomatic, people who inject drugs. But reaching them, we need community engagement. Differentiated service delivery. We have already moved from genotype. We have pan-genotypic drugs. APRI score has been modified to less than 0.5 to diagnose as cirrhosis. Task shifting. identify cases which really require a specialist care and opinion, and have linkage for referral so that we don't lose them on the way, dedicated funds, and prevention through bird dose vaccination, needle syringe program, exchange program, opioid substitution therapy, and vaccinate people at high risk for hepatitis. Thank you for your attention.